Joe,
Yes, sir. So we are live
before
on
you,
YouTube, sir.
before you start your speech, you just say welcome all. Just give us 2 3 minutes to enter everybody and all
Yes,
that,
sir.
and
So we are
then you
live.
start.
Yes, sir.
Okay.
Yes, sir. Good evening, doctors. Welcome back once again to the free webinar conducted by Online Dentistry. Thank you all for joining us early. Please make yourself comfortable while we continue to admit the candidates in Zoom and on YouTube. All candidates who require a certificate of participation for the program, please ensure that you have registered a free account on our website and have enrolled for this program. Welcome all once again to the free webinar conducted by Online Dentistry. Please note, all candidates who require a certificate of participation for the program, please ensure that you have registered a free account on our website. Dear doctors, sit back, relax, grab a pen and paper as it's going to be a knowledge packed session today. Thank you, doctors, for joining in early. We'll be starting shortly. I think we are stabilizing well on both YouTube and Zoom. So good evening, doctors. Welcome once again to the free webinar conducted by Online Dentistry. Online Dentistry is a firm dedicated to imparting quality knowledge to dentists globally. Our motto is to redefine the dental education system that is available to dentists. We have been striving towards the same the past 13 years. Here is our 12-year history in numbers. As you can see, we were established in 2008. We have conducted a total of 122 offline courses, and during this lockdown, we have conducted 395 online courses. At present, we are amassing a total of 15,500 plus followers on all our platforms combined. This organization was founded and is led by none other than our beloved Dr. Binuti Abraham. Sir is a dentist by profession, but a teacher by passion. Sir is a world-renowned speaker and has been a keynote speaker for the ISPPD for the past 6 years. He is a teacher who simplifies the clinical concepts in dentistry so that practitioners can implement them the very next day. Introducing the head of academics, Professor Dr. Joby Peter. Sir is a teacher and a veteran pediatric dentist. Sir is at present heading the Department of Pediatric and Preventive Dentistry at the prestigious Malabar Dental College and Research Centre, Kerala. Sir, throughout his career, has practiced and preached the philosophy catch them early and watch them grow. Over the past 10 years, online industry has grown to 10 centers across India, truly redefining the concept of continuing dental education. We thank our coordinators at each center who have supported us throughout the years. All offline courses are at present suspended due to the restrictions of the pandemic. We have been receiving several requests all along this year regarding the offline courses, and if the situation of the pandemic resolves quickly, we will be coming out with an offline course soon this year. Regarding the types of webinars that we conduct, we have both free webinars and paid webinars. Free webinars, like the one that you're attending right now, is a 1 hour webinar that is packed with information, and all candidates are eligible for certificates of participation, and at times we even give out free goodies. In the paid webinar is a 1 full day program with again a certificate of participation, and there will be extensive discussion and virtual hands-on on the topic that is covered. And there is a post-class support that is provided through WhatsApp groups that helps redefine the dental education that we are providing. Now, the upcoming free webinars are on two very interesting topics. Why I say interesting is they are topics that are least explored by general dentists. On March 7th, we have the program on sectional orthodontics, and on March 14th, we have another topic which is indeed will redefine the way general dental practitioners outlook towards cleft lip and palate and the initial interventions. The upcoming paid webinars are on lasers in dentistry on March 7th. This is the second time we are launching this program due to multiple requests from the candidates who missed the previous session. The speaker, Professor Dr. Sharvana Kumar, is an international laser trainer and an amazing mentor. On 20th March, we have the paid 1 full day virtual session on sectional orthodontics hosted by none other than our CEO, Dr. Binuti Abraham, which will indeed be an eye-opener on the topic for many. Do attend this free session that is coming up on 7th March to understand the significance of the topic in daily dental practice. Now, an announcement on online dentistry going international. Dear doctors, it is my proud privilege to announce that online dentistry is officially associated with the Faculty of Dentistry, Lincoln University, Malaysia. It is indeed a milestone achievement for the team. We thank all our dedicated candidates who have attended our programs and helped take online dentistry to the next level in dental education. Further details will be shared by the dignitaries who have joined us for the inaugural session. For more details about us and about our programs, visit www.onlinedentistry.in. And if you are not yet a member on our WhatsApp group, please send us a message on 9847032032 and 9446321220. Thank you for your patient listening. Over to Dr. Gobu sir, faculty in charge for Lincoln University, Malaysia.
Joe, Dr. Gobu has some issue with connectivity, I guess.
Yes, sir. Sir is joining right away, sir. Audience, please bear with us. We'll be connecting shortly. So Gopi sir is here, sir. Gopi sir, you can unmute yourself now, sir. Over to you, sir. Gopi sir.
Gopal. Only, huh? No problem. Okay.
Hi, hello everyone. I think you can hear me now.
Yes.
It's a great pleasure for me to be in this forum. I would like to share my screen and then discuss a few things about Lincoln University and online dentistry collaboration. Hope you all can see my screen.
Yes, Dr. Gopal.
Thank you very much. Thank you very much, Dr. Bino. Thank you very much, Dr. Joby, and thank you, Online Dentistry, for having a wonderful day today. It was indeed a great pleasure, and among our struggles, we joined hands from overseas. It was a great effort given by our Dean, Dr. Pushparajan, our President, Dr. Amia, along with all the two CEOs of the online dentistry, and Dr. Joby, his work. We all work together to make this event a great success and the forthcoming events to be much more useful to our dental fraternity. I take this opportunity to introduce Lincoln University College for all of our benefit. The motto of our university is education for all. As the name states, it gives us a great pleasure to be part of everyone's life in developing dentistry and also the other part of the master's program and PhD program. So our focus is student-centered and student-directed. Our philosophy is that everyone has a claim to education. That is what our MD is very, very keen about. My president has a very broad mind. He wants education for all as his theme and motto. And as per the statement, he is very cooperative in extending our collaboration across the countries, along with Africa and also in Asia. So Lincoln University is very proud to be part of online dentistry's effort. We have been going through the online dentistry and their effort during this pandemic. Their commitment towards dentistry has given us an immense pleasure to join hands with them. Thank you, online dentistry, for your effort and for this collaboration. Our vision is to be an acclaimed institution of higher learning that provides world-class education with high capability in providing knowledgeable and skillful professionals to serve the global society. That we go about with this mission to become a truly global university. We are recognized and accredited by all the high-ranking universities and organizations. So the most important being the Ministry of Higher Education and the Ministry of Qualifying Accreditation. Along with that, we have already been introduced and also been accepted by the Medical Council of India. Our medical course is approved by Medical Council of India. So people around India can come over here, join our medical course and benefit from that. We are also part of Association of Indian University, which gives us a cutting edge benefit for those who wants to pursue their PhD to be accredited in their faculty level as per the government's UGC scheme. So you can take this opportunity to join hands with our PhD scholars, with our PhD supervisors, so that you can start earning your PhD degree, and that is accredited by our Indian university. The field of studies that we are very strong are in medicine, dentistry, nursing, pharmacy, health science, hospitality and tourism, business and accountancy, social science, engineering, computer science, and pre-university studies. The list of PhD programs are this, where we concentrate on PhD in health science and medical physiology, whereas in PhD in health science, we do concentrate on medical and dental PhD programs, and we are on We are on program approval rate where we are about to get our PhD in dentistry soon. Separately, we have around 28 master's program. Out of that, Master of Science in Dentistry by Research is one of an important program that has been added along with our DDS program. And I really thank and take this opportunity to join hands with online dentistry because they have provided a lot of courses to a lot of people in and around India. They have a very wide and vast experience in clinical practice. I really thank Dr. Binu, Dr. Joby for their continuous effort throughout this pandemic to make everyone's life much more simple, easier, and keep up our knowledge throughout this pandemic without losing our heart. So I hope by doing this collaboration, we are very happy to join hands with this effort to create and to make our effort much more fruitful to keep our motto of education for all. Thank you very much for this support and hope our online dentistry collaboration will move forward. I would like to call upon our Dean, Professor Dr. Pushparajan, to be on this medium to have a few words about this collaboration and inaugurate this event. Thank you all. Once again, I thank all the dental fraternities, my dear colleagues, to be in this part and hope we can enrich our knowledge throughout continuously. And I welcome everyone. Please welcome to this online dentistry LUC collaboration. Thank you. Sir, please come, sir. You can take up this.
Sir, you have to unmute.
Yeah.
Yes.
Able to
Yes.
hear me?
Yes,
Yeah.
sir.
Yeah. And Dr. Binu and Dr. Joby and all the other participants, I have been greatly honored to have been invited to inaugurate our first online dentistry program in collaboration with the Lincoln University Dental Faculty. As a dean of this faculty, especially the dental faculty, I am proud to be associated with the most famous online dentistry from India. I know and Dr. Binu and Dr. Joby Peter for many years, and I am very proud to say that in fact I was the student of them, though I have crossed well over 75 years. I'm very proud to say that I have been their student for quite a few times, for quite few programs I have attended also. Though I have been practicing dentistry and especially the myofunctional therapy for well over 40 years, I have polished my knowledge only with the help of this two young educationalists, Dr. Binu and Dr. Joby Peter. And I sincerely thank them for all the coaching that they have given to me. And in fact, I'm a practicing periodontist as well as a good, I don't know whether I'm a good academician or not, but I have been an academician for quite many years. But my main concern is in my practice is the pediatric orthodontics, where I am really very good, very much interested in fact, okay. In my clinic, we are 3 people who have been practicing this art of myofunctional therapy, okay. And I am really very happy to have a very good collaboration with one of the most renowned online dentistry educationalist from India. So I would in future request many of these participants who are coming for the free program to attend even the paid program also, because this program that they are conducting to prevent the malocclusion is of immense value. You see, I still remember when I started my practice to this day for the past 50 years, what an amount of advancement that the dentistry has gone. From the foot engine to cutting the tooth for filling, we have come to aerator and high-speed engines and so forth. And when we talk about the myofunctional therapy or orthodontics, we just had only few orthodontic appliances when we started our practice. That is Hollis appliance, I still remember, and 1 or 2 bite tracing appliances. That's all in 1970 when I started my practice we were doing. And that too, very sorry to say that our teachers even won't teach us. They will just hide and adjust the Hollis appliance loop. But now, this generous young gentleman, 2 people, Joby Peter and Dr. Binu Thomas, has been very kind enough, have been very generous enough to explore and to carry over the knowledge to all the young general dentists all over the world at international levels. I wish them all the best. And with great pleasure, let me inaugurate our first collaborative program with the online dentistry named Early Management of Developing Malocclusion. Let me inaugurate the program. Thank you very much. Yes.
Thank you very much, sir. Thank you very much.
That's a digital lightning. Digital lightning the lamp, sir.
Okay.
Thank you, sir.
Thank you.
Up next, we have Dr. Tan Wen Wu here to introduce the speakers of the day.
A very good evening to our respected Dean of Faculty of Dentistry, Lincoln University College, Prof. Dato Dr. Pushparajan, our Deputy Dean, Associate Professor Dr. Gopu Chandran, and our highly esteemed speakers for today, Dr. Binu and Dr. Joby, and our participants who are here with us this evening. I'm Dr. Tan, lecturer from the Faculty of Dentistry, Lincoln University College. It is wonderful to be with you all this evening and lovely to see so many participants who are eager to learn from our experienced speakers. So let me just introduce our speakers of the day. Dr. Binu Thomas Abraham completed his Bachelor of Dental Surgery from College of Dental Surgery, Manipal in 1994. He went on to New York University to do his postgraduate diploma in orthodontics in 1997. Upon completion of his course, he worked as a lecturer in New York University for another year before returning to India. He then worked as a senior lecturer in College of Dental Surgery, Manipal until 2001. Presently, he's running a private practice in Aluva, Kerala for the past 21 years. Dr. Binu is a fellow of Academy of Dentistry International and International Association of Facial Growth Guidance. He is also a member of International Association of Orthodontics, member of European Orthodontic Society, and member of American Dental Association. Our second speaker of the day, Prof. Dr. Joby Peter, graduated from Manipal College of Dental Science, Mangalore, under Mahe University. He finished his postgraduate in Pediatric and Preventive Dentistry from Raja Mutia Dental College and Hospital, Annamalai University, Chidambaran, Tamil Nadu. To his credit, he has multiple national and international articles in various journals. He also co-authored a chapter in Textbook of Pediatric Dentistry by Prof. S.G. Damley. He also holds a postgraduate diploma in Criminology and Forensic Science. He's also a certified trainer for Tobacco Intervention Initiative Program from National Institute of Mental Health and Neurosciences, Bangalore. He's currently the professor and head of Department of Pediatric and Preventive Dentistry, Malabar Dental College and Research Center, Kerala, India. Under his guidance, 8 research projects are undergoing, and one of his postgraduates secured second rank in the university master's program. Dr. Joby is also a member of Indian Dental Association, Indian Society of Periodontics and Preventive Dentistry, American Academy of Pediatric Dentistry, Academy of Applied Myofunctional Sciences, California, USA. He was also invited as the international guest speaker for Academy of Dentists International, New York, AAPD, Nash Visual, USA, Kenya Association of Pediatric Dentistry, and Al-Iraqi University, Baghdad, Iraq. He's one of the coordinator and chief faculty in a firm called Online Dentistry, dedicated to online and offline training for dentists, and have done over 300 webinars during this lockdown to support fraternity with clinically oriented topics. He holds the LIMCA Book of Record, Asian Book of Record, and Indian Book of Record for traveling in his car for 10,000 kilometers in 27 days, covering 13 states for a noble cause of tobacco-free India, a nationwide campaign organized by Indian Dental Association Central Branch under the guidance of President Dr. George Thomas and Secretary Dr. Ashok Doble. Has been invited to give more than 180 guest lectures, 120 CDE programs with hands-on in Indian Dental Association, ISPPD, ADI, TII centers, and at various regional and national arena, and continuing. Without wasting any more time, I'd like to pass on the mic to the first speaker of the day, Dr. Binu Thomas Abraham, to give us his talk on today's topic. Please, Dr. Binu.
Thank you very much, Dr. Tan. Thank you so much. Thank you, Dr. Pushparan sir, Dr. Gopu. It is indeed a privilege. It is indeed a great moment for online dentistry. 10 years before, sir, when you came down to Alua, my clinic, to attend the program, you were the senior most student for a 65-year-old. Now you are above 75. Extremely happy that the relationship is still going on so strong. And now we have reached this landmark situation of tie-up with the university you are in. And we are really happy about that. Joe, can I share the screen?
Yes, you can, sir.
Is my screen visible?
Yes, sir, it's visible, sir.
All right. One blind boy was sitting and begging with a signboard written there, "I am blind, please help." Many people passed by. He didn't get much money. But one day, this fellow came there. He felt a little sad about this kid and wanted to help the kid. He couldn't help him financially. So what he did is he took that signboard, wrote something on that signboard and kept it there. On the other side of the signboard, he wrote something and kept it there. My God, this kid's life changed after that. Money started pouring in. Kid was so happy, his life changed. One day, this fellow came there again. When this fellow came there again, this blind kid asked this fellow, "Sir, what did you do to my signboard? You changed my life. What did you do to it?" He said, "I didn't do much. All I did is I changed the wording." The wording was what? "I'm blind, please help." I just changed the wording to, "Today is a beautiful day, but I cannot see it." Guys, that small change in the mindset of that person changed the life of the kid. Guys, my topic today, for hardly 10 minutes today, I'm talking only for 10 to 12 minutes today, is on change of attitude. Attitude has to change in private dental practice first. Change of attitude. When I say change of attitude happens in every aspect of dentistry. Let's talk about class 1 crowding. You see a crowding, immediate thinking, look at the upper arch, look at the lower arch, severe crowding, immediate thinking will be extract 4 teeth and do orthodontics. Why? Why are we not thinking in terms of expanding? There are so many expansion devices available. I'm not getting into any details here because Dr. Joby is going to cover that soon. There are slow expanders, rapid expanders that can literally split open the maxilla, by which you are actually improving the airway of the patient. Attitude change, guys. Have you ever taken a frontal X-ray, PA view X-ray? Have you ever taken? Everybody is doing lateral ceph. Everybody is doing lateral ceph tracing. I know that. But are you doing something called frontal cephalogram tracing? That's available. There are frontal cephalogram values. A lot of values are there. I cannot go into all that. All I want to tell in this platform is internasal width, IN. Internasal width, IN of this particular patient is 26 millimeter. After rapid palatal expansion, after RPE, splitting open the maxilla, the internasal distance became 29. We're talking about 3 to 4 millimeter of air nasal widening. Guys, let me tell you one thing frankly here. 9 out of 10 rapid palatal expander cases I do in my clinic, I have heard parents telling me, doctor, I don't know what is happening to the teeth. There's a gap forming here and all. It looks a little ugly, but that's all okay, doctor. But one thing I know is my son is sleeping better now. He's not getting up in between his sleep. He's not talking in between his sleep. My son is sleeping better after you put that thing in last 14 days of expansion. I bet, Dr. Vinod, I've seen my son is sleeping better. Guys, oxygen saturation improves the moment you get that airway increase. Frontal cephalogram proving this, that rapid palatal expander is the nasal flow. You are basically splitting up the maxilla. You can see a occlusal radiograph where the maxillary sutures are split up by rapid palatal expansion. And there are a lot of articles proving that the airway is increasing once you do this. The moment airway increases, guys, sleep becomes better. The moment sleep becomes better, the attention deficit disorders the kid has goes off. We have seen all that. Guys, change of attitude is what I'm talking about. Change of attitude towards that simple crowding which you see daily. Tomorrow morning, you will see a 7-year-old with crowding. Tomorrow morning, you will see a 8-year-old, 9-year-old with open bite. Attitude has to change towards open bite also. This female came to me at the age of what, 9 or so. I noticed that, if you can see my mouse movement here, I noticed that there's a small bump forming on her nose. And I noticed that her face is slightly longer for her age. Told the parents that there is an issue with her tongue positioning. Look at her crowding already started. Told the parents about the tongue positioning. They never listen. See, you tell, they may not listen. That's a different point. And then the same patient came to me after 3 years. This is the same patient after 3 years. Look at the nose hump, which has increased. Vertical has increased. All that happened just because of that faulty tongue position. And look at the open bite that formed in 3 years' time on the same kid, just because they never listened to the dentist on the importance of tongue positioning, importance of better swallow, importance of better breathing of the patient. Open bites. And then there is even a lawsuit that happened in America. In that lawsuit, the judge actually punished the dentist. And the terminology the judge used is called as supervised neglect. There are so many dentists listening to me now. You supervise an open bite every 6th month. You see the patient. You do fluoride therapy. You do fillings. You do everything beautifully. And parents actually ask you, doctor, there is something wrong with the way my child bites. That's okay. At the age of 13, we'll deal with it. Every step, but I've done the fluoride. There's no cavity. Your kid is doing very good. But what about that small opening forming here? Is that okay? That is okay. At the age of 13, we'll take care. The judge named this concept called a supervised neglect. Every 6th month, it was monitored nicely, but it was neglected. Now, a patient comes to me, adult, as an orthodontist, an adult patient with an open bite is always a nightmare. What can I do on an adult like this with such a huge tongue out like that? What can I do orthodontically? Look at this. I can align upper arch, lower arch nicely. I can put a tongue trip inside. I can talk a lot. I can tell a lot. I can put box elastics and bring everything together. Whatever I do, believe me on this, it will relapse until and unless the tongue position has been corrected. He has to live with a tongue grip the rest of his life. Come on, is that the way to go? That is why I'm telling you, change of attitude is required in every aspect of malocclusion. You see a malocclusion at the age of 7 years, 8 years, it is not going to improve. It is only going to worsen, no doubt about it. So that change of attitude has to come in every aspect in dentistry. One more case, single tooth in crossbite. One tooth in just one teeth, no, it is okay. Leave it. We'll correct it later when he's 11 or 12, we will correct it. You are changing the complete growth pattern of the maxilla and mandible by neglecting that. And this case is a proof. This case is a proof. This case came to me 15 years later, like this. One single tooth in crossbite being neglected. Now, look at what happened to him. Complete facial asymmetry. Complete facial asymmetry because of one single tooth, which could have been easily corrected with an Z spring or a sectional orthodontics or whatever, but was not corrected. And look at him now. What can we do at this stage? Only an orthognathic surgery can save him. Of course, orthognathic surgery made him perfect and great, but he has to live with all these plates rest of his life. If he had been treated with an Z spring or 2 brackets, 2 by 2, 2 by 4. But attitude, change of attitude is required towards many, many things, including the golden words which dentists always say in private practice: come back after the age of 13 years. That at least at the end of this session by myself and Dr. Jobby, my humble request, remove that tagline, come back after the age of 13 years, which is wrong. You have to start screening from the age of 5 and start intervening from 6, 7, or the moment you see a malocclusion. Now, concepts are changing. Holistic approach is the way to go now, and newer diagnostics tools are in place now. Holistic approach. What do I mean by holistic approach? You are supposed to look at the posture of the patient. Have you seen your patient sitting in the waiting area? You should ask the patient to sit in the waiting area for some time. We have the CCTV camera. Myself and Dr. Jobby, during his visit to my clinic, we sit and watch in the CCTV camera how the kid is walking inside, how the kid is sitting in the waiting area. You can see the shoulder coming forward. Check out all that. Why is that? That is because of improper breathing, improper tongue positioning. And that added to that, you have an iPad or a mobile in his hand. You can see the kid sitting like this full time in the waiting area. Seen all that. It has been proved that it is almost 6 kg kept there, kind of an impact. You sit with the mobile or an iPad all the time, and the kids are sitting like that. And parents are happy because the kid is not disturbing. He's in his iPad, and parents are sitting with his WhatsApp again on the other side. So that has an impact on the kid. Holistic approach. Everything has to be checked. Breathing. Such a cute kid. Hallmark card, the greeting card picture. But let me tell you, this kid is struggling to get air. Bump up, mouth open, sleeping posture, proving that this kid is struggling to get air. But it's so cute. Breathing, airway, posture. Have you checked all that? We are so busy to look inside the mouth. Are you looking outside? Are you taking the things happening? Are you looking at the effects of this? There's something called compressor theory. Compressor theory is nothing but the tongue becomes lower. The moment the tongue becomes lower, the cheek muscles take over. When cheek muscles take over, there's an imbalance between the tongue and the cheek. The moment tongue comes down, you can see the cheek muscles taking over, and you can see compression of the arch starting. The moment you see that, intervene right and there with myofunctional exercises or appliances. Otherwise, you are only going to worsen it. It is not going to improve. You will reach severe collapses like this. And when you see a lateral step, are you going back and seeing the adenoid, or are you still stuck with looking at the teeth? SNA, SNB, conventional stuff. Are you looking at the adenoid, looking at the airway? All this comes under holistic approach. And newer diagnostic tools are available now. Dr. Joby is going to cover about that also, so I don't want to waste time. All sorts of newer concepts are there. No more SNA, SNB, and all that. Steiner's analysis, Down's analysis, Tweed's analysis. You mugged up all that, I know. It's growing up, guys. For a growing kid, it's in a different concept altogether. Newer archival analysis is coming, wherein full face is being taken care of, not just S point and N point determining where should be A point. No, it's not the way to go anymore. Guys, change of attitude is all I want to tell as a conclusion. Look at the gait of the patient, how patient walks. Have you checked that? You can get a lot of clues from that. Have you checked the posture of the patient? Check the face of the patient, full face of the patient, breathing pattern, swallowing pattern. Have you asked the patient about have you asked the parents about how the patient is sleeping? Have you asked about it? You start talking from tomorrow onwards about sleeping. Oh, doctor, don't tell me about sleeping. This fellow rolls around in the bed. He need one full double bed. Morning, I can even see him under the bed. He is so restless. What does that mean? His oxygen saturation level is way below whole night. It has an impact on his studies, on his daily activities. So change of attitude, that signboard change is what I'm stressing on. Today is a beautiful day, but I cannot see that change of attitude is all I wanted to tell here to start off with. Thanks a lot. Thanks a lot, Lincoln University. And over to Dr. Joby now. Joby, it's your turn. I'll stop my share. Thank you once again.
Yeah. Good evening, all. Is it clear, Dr. Binu?
Yes, sir.
Yeah.
Yes.
Thank you so much. Thank you so much, the Lincoln University, Dr. Pushparajan sir, Gobu sir, and Dr. Tan for coming all the way and being in this platform and giving you this opportunity. Thank you so much for your trust in us. And as Dr. Binu told today, I will be continuing with what Dr. Binu has left behind. And thanks for the wonderful introduction given by Dr. Tan. Hope someday we will meet in Malaysia. We will work together. Hope all things works better. So my topic of today is a continuation of what Dr. Binu said. So I named this topic as designing the road to better function and occlusion. So if you notice the heading itself, I'm not bothered about occlusion first. I am not even bothered about the occlusion. I am bothered about the function the child is performing. That is what Dr. Binu was stressing. His indirect aim was whether the function is correct or not. So this is going to be a different situation that I'm going to discuss from what Dr. Binu has said. So this is my college. I welcome you all to my college. I'm working in this college as a professor and the department. We have a separate pediatric session with exclusive focus on to the myofunctional or full setup of myofunctional anira there. So you are all welcome to be with us. I am not calling you. Do not worry. I am not calling you anyone. But this was the sound that is ringing in our 80s and 90s in our home. We love to have this setup in our home. And our loved ones used to call us and we used to pick up the call and listen. And how are you? Where are you? How is that? That sound is nostalgic. And when I went to pursue post-graduation, the only way I can contact my parents on Saturday evening, the weekend, is through this local booth you go to this booth, stand in queue, get your terms, and then you call them and people will bang, it's time up, come out, I want to call, because there is nothing more, because there is no other options in front of you. So we used to this for many years. But one day, one guy came forward. He changed the concept. I hope you know this guy. Is none other than Martin Cooper. Martin Cooper changed the concept. He brought something called mobile phones. When he brought the mobile phones, the world started moving. I mean, anywhere, any part of the world you are, you can call, you can talk, you can discuss, you can do anything. So hats off to Dr. Martin Cooper. Today, I'm seeing you in Malaysia is just because of the innovation in technology. And second part is adaptation. I adapted the technology into my professional field. That's why I am seeing you and you are seeing me. So he changed it. But initially, it was just text messages. You remember this Nokia mobile? So just text messages, no voice call, nothing, just text messages. But now the world has changed. From there, from that ringing bells, it is changed into this. And now it is like you can have a WhatsApp call without any cost. You don't have to spend any money from your pocket. You can call, you can see live your dear ones and loved ones, your girlfriends or boyfriends, whoever it is, you can call them and you can have a chat with them and feel as if you are with him or her. And boredom has come. So basically, what have we done is we have changed from this ringing bell to this, we have changed. We have changed. Tell me anybody is still using that old ringing mobile phones now? I don't think so. We have changed. Everybody has moved on and we have changed. So I want to make a statement here. Change is the only constant thing that is happening in around us. This is the only constant things that is happening in around us. You like it or not, change is happening. So my next question is, are you ready for the change? We practicing dentist has to change. Are you ready for that? Because change is inevitable. You can seal yourself in four walls, but after 10 years, change has come. Except for Pushparajan sir, he has not changed after 10 years. I'm seeing him, he's still the same. But let me tell you, change is inevitable. It will happen. And progress is optional. Whether you want to take the progress and march ahead is optional in front of you. So that's why I termed this entire session as designing a road to function and occlusion. First, function has to be taken care. So you want to walk in a road. So first, what moves first? If you want to walk from your room to the bathroom, what has to move first? The skeleton has to move first, and followed by, supported by the muscles. Whatever you want to do, the skeleton followed by the muscles supporting the skeleton has to be done. That's the entire process of the body. Let's see about the masticatory system. Let's focus on our part, dental part. You want to chew and swallow. You want to breathe and swallow. You want to sleep and get a good night's sleep. You want to have a good food in front of you. You want to chew that food and you want to enjoy it. There is something happening behind what your desire want to do. The muscles and the skeleton should follow together so that you can have a harmonious relationship or enjoy the food, and at the same time you are satisfying your hunger. So entire body It's not just the crossbite or the dentition we dentists are dealing it. We are dealing with the entire human body. You might have heard about mouth is the mirror for your oral cavity is the mirror for your human body. Why? It's all happening around the mouth. Because the basic need for you to survive is in the mouth or nearby around the mouth. We are dealing with that. So what are you going to take home message from my next 40 minutes of presentation? You are going to take home some points. You can have a paper pad, scribble it down. Believe me, Monday morning, tomorrow morning, you might be noticing this thing in your patients. That's why take home message points for you. You note it down, you will be getting these points. What are the points you're going to get? How to identify a developing malocclusion. Very simple, you might feel, but I will be explaining you what you have missed it, identifying a developing malocclusion. Now, if identified, first question should be why it has developed. Then how it will affect the whole body. Is it has got a relation to the whole body function or not? If so, how to correct it? How can I correct that? And some case discussions. So all of you, it's not going to be very complicated formulas, anything. It's going to be very simple methodological way of treating a patient in your clinic. So I'm going to start with simple case discussion first. To have a case discussions, I need your interaction. So those people who are in chat box, who are in good in that, you can put in the chat box. I'm going to project you a case, a simple case that has come to me around 12 years back. Okay. So the child was around 4 to 5 years of age. Just 4 to 5 years of age, the child was. And this was the clinical situation of the child. When they came, they were worried about that crossbite. Can you see a crossbite there? There is a unilateral crossbite. One segment crossbite was present. Child was 4 to 5 years of age. Now, if we want to go ahead, please open up yourself, come to the chat box and type what will you do for this? What is your treatment option for this? What will you do for this? Can I get an answer for that? Arch expansion, Dr. Sneha, very good. Wow, very great. You said arch expansion. Arch expansion, Dr. Pavan, arch expansion, fine, fine. And 4 to 5 years, what will you? That's why only 2 people had unilateral expansion. Dr. PA, I don't know her name. Okay, great. SME, slow maxillary expansion, great. Please put on the chat box what you feel to do for this guy. Arch expansion, correction of the crossbite, arch expansion, bite opening, great. Any functional shift, oh great, okay. Ask about habits, tongue exercises, SME, oh so many answers are there. Great. That's amazing. That shows your interaction with this topic. Let me tell you, be interactive, you can change your practice. Be a general dentist, pediatric dentist, whoever you are is going to change your practice. Yes, what you said is right. What you said is exactly right. You have an option, and that option, whatever said, is there. Now, let's talk about, let's see this case little more very close to my heart, because this came after 10 years. After 10 years, the same patient, whatever you said now, I told to this patient, you have to expand, you need an appliance, you need this, that, so much detail I gave to this patient, but they didn't come back to me. But after 10 years, this patient came back to me, and now I want to show you the same patient's real picture. Around 3 weeks back, they came back to me. Let's see the same patient's intraoral picture. This is the same patient's upper arch. Okay, this is the upper arch, and this is the lower arch. Fine. There is no much cross-bite. There is no much cross-bite. No treatment the patient did. They did not do any treatment, but there is no much cross-bite. This is the occlusion. This is the occlusion. There is no cross-bite. You can see there. It's auto-corrected, or is it? I don't know, but it's auto. This is the condition when I saw this patient there. So should we do a treatment now, or am I wrong in saying that you have to start the treatment? But when I did a close thing, I analyzed one thing, that there is a midline shift there. There's a midline shift that is happening. See the midline, it is being shifted left. There's a shift in the midline. Okay, that's okay. Developing dentition, midline shift can happen, and later you can correct. Why you want to worry about it? But still that primary molar is in crossbite. Look into that. That primary molar, after 13 years, she's now 13 years or so she is now, still that primary molar is in crossbite. Permanent molars are not in crossbite. So you might say, okay, this is going to shut off after the premolar is going to come erupt, it will adjust by itself. So this is a real clinical situation. That happened at 3 to 4 years of age, is still continuing at 13 to 14 years of age. That primary molar, second primary molar is still in crossbite. Patient is not worried, no problem. Midline is even shifting. You know, now this patient is sitting in front of me. The same patient is sitting in front of me, of not worried about crossbite. They are worried about something else. 13, 14 years, they are worried about something else. Let's see what they are worried about. The mother is worried, the entire family, the relative, the child is worried about something else. They are really worried about something else. Doctor, we saw you in 3 to 4 years of age. Now, you told us to do something, but we ignored. But now we are really worried. Can you do something? Can you do something? They are worried about something else. So let me show you the picture as if you are seeing this child for the first time. This is a frontal not smiling. Can you see anything on our frontal not smiling? I don't think so. What about the smiling? Here comes the patient compliance. Mother said, sir, when she smiles, one side gum is more seen. One side gum is more seen. Other side is okay, but one side, whenever she smiles too much of gum on one side is seen. Other side is okay, we are happy. That is the complaint now. And they say that for the past 1 year, it is increasing. We went to multiple clinics. They said, don't worry, don't worry. So that's what we will show you. One side, it is too much increasing is there. Do you find anything in this? Let's discuss that. Smile deviation, facial asymmetry. Oh, great, great, asymmetric. Let's see this girl's true. Yes, there is a total facial asymmetry developed for this girl. Total facial asymmetry has already developed for her. Her smile has changed, and now they started noticing it, and in front of you, what can you do this? This is the OPG. This is the orthopantomogram of her. And if you see, there is no issue with her. If you see, there is no issue. This is the same OPG I posted in all the groups, all the WhatsApp group you are there. I posted this OPG. An interesting case. Be with us. You will be mesmerized to see what has happened here. This is the orthopantomogram which I posted in all the groups, and I will be discussing this. The same OPG. If you see the OPG, there is no much problem, because D is about exfoliate, premolars are there, which is bigger or smaller than the primary second molar, so no issue. Technically speaking, occlusally speaking, space-wise, she is safe, no problem. But OPG revealed something else. Now, the mandible, the right mandibular condyle, the length of the right mandibular condyle was increased. Length of the right mandibular condyle was increased. The coronoid notch was very prominent. Coronoid notch. See, the coronoid notch was very prominent. Let's see on the other side. Normal. Other side, mandible is developing normal, no problem. Coronoid notch is also normal, but the right side is developed too much lengthening of the condyle has happened. Now, look at the angle of the mandible. It's more curved. It's not angulated. It's more curved. It's very curved. And the other side, it's more angulated. She was diagnosed with something called unilateral condylar hyperplasia. Unilateral condylar hyperplasia. Do you know the reason for this? There is no genetic de novo, you can say, and ignore it, but there was a reason for this to develop. That means one side of the condyle is getting hyperplastic, other side is normal. And because of that hyperplastic, the deviation, the midline deviation, increase in the length, facial asymmetry. It's not hemifacial hypertrophy. If you see the eyes, every part of her face is normal. Only the mandible was excess on one side, or condyle was growing on one side. If you want to read more about it, read this article. Lateral Function Shift of the Mandible, Part 1 by Maria Angels et al. Effects on condylar cartilage thickness and proliferation. An article you must read when you start talking about mandible. Their Part 2 is amazing. Gene has got a limitation, and it is all not the gene, function. Mandibular function also plays an important role. Let's talk about this case. What function Dr. Joby is talking about? What's this kind of shift in a mandible there or not? So whenever you see a clinical case to 4 to 5 years of age with crossbites, I am not talking about crossbites. I am talking about younger age patients when you find with 4 to 5 years of conditions like anterior crossbite or a posterior unilateral bilateral crossbites, we always go into options. We try how to correct it. Doctor, there is an option to correct it. Should I correct it or not? That is what our aim. Or can we leave it? My simple question to you is, forget about how to correct it. Forget about how to correct it. Learn why it is happened first. Why that crossbite or unilateral anterior posterior, bilateral anterior posterior crossbite happened. Learn that first. Then it is easy for you to correct it. We go other way around. We try to give appliances, we try to give a lot of gadgets to the child or the patients and make it so cumbersome for them and try to correct it. That's not going to happen. Let's go why it has happened. So look out these features. Believe me, look out these features. So whenever you see a crossbite in primary dentition or early mixed dentition, believe me, these are the list out topics that you have to look in. Take a paper, pen and paper, write it down. These are the questions you should be asking the mother. What are the questions? Is your child is on soft diet? A 4 to 5 year old child should not be in a soft diet. He cannot be in a soft diet. He cannot be in a syrup. He cannot be in porridge. He cannot be in soups. He should be having or chewing or mastication should be well established in a 4 to 5 year old child. Parents succumb to the child's demand and give whatever child wants, but they don't take care about that. So ask them, what is your diet pattern of the child? Parent says that, he eats only soft things. You gave him crushed, you gave him everything in the juice he eats. That's it. Nothing hard. This child, 13-year-old, says that she doesn't eat any fibrous food. At age of 13, she do not eat any fibrous chewing food. That's not good. Poor mastication. Chewing on one side. Child says that she only eats on one side. She doesn't chew on both sides. You need to chew both sides. When you chew on both sides, the muscles of mastication compresses and the jaw grows. When you get tired on one side, tongue will push on to the other side. When you get tired and soreness on the other side, tongue will push to the other side. So it's like a cycle, right, left, right, left. Chew, chew, crush the food, make it soft so that you can absorb it. That's a normal cycle. It has to happen. This child, 13 years of age, she eats only with one side. Till now, she eats only with one side and she pouches the food for a long period of time. For her to eat one bolus of food, take 20 to 30 minutes. One plate, 2 to 3 hours, she finishes it. Pouches the food and swallows there. And occlusal interference. That was one reason for. There was a sharp, because there is no attrition. Physiological attrition is immaterial for her because she don't masticate, she don't take hard food, she don't chew on both sides. So there is no physiological attrition. The sharp canine edges are still the sharp, they are not rounded off. No lateral excursion of the mandible. So what happens? Occlusal interference still persists and patient adjusting to get a bite, at least one side to get them. And tongue tie. Another missing aspect is presence of a tongue tie. You never ask, you never check. Tongue or lip tie is present. No matter occlusion is perfect, everything is perfect. If there is a tongue tie or a lip tie which is present, can have a problem of this. So what I'm going to explain to you is facial development has got something called form and function. Form makes the function and function grows into form. So breathing, swallowing, and mastication is the basic function. That's what Dr. Peter was telling. You have to breathe to survive. Okay, you survive. Then you have to swallow the saliva. You have to eat. You have to suck the milk from the mother's breast to survive first days of your life. So swallowing and mastication must be present along with breathing should be present in a proper way so that function is happening and form develop according to that, like your jaws, your face, your teeth, your posture also adapts into the best. You can perform the function there. So that cycle continues there. So the question comes, sir, okay, fine. Then we should start looking into these problems. When should we start looking into the problem? When you start seeing this problem, let me tell you, it should be from the initial stage, right? From the birth, you should look into this problem like a tongue tie in a 3 days, 10 days, whatever, if it is present, according to the protocols has to be followed and it has to be removed. Or if there is a lip tie, upper lip tie is present, if you notice, if it is need to be taken off, it has to be corrected. So there is no time limit. Any time you start is good for that patient, not 13 and 14 years. Let me tell you, anytime you identify this, start at that time. Analyze the protocols which you're going to tell. That is the best for that patient. You can't rewind your time. You can't rewind it. At what time you are getting, if you're getting at 6 months, if you find the problem, what I'm telling now, start, at least attempt and start. You're getting at 6 years, start. Do not wait. Anytime you're getting is good, not 13 and 14 years of the time. So tongue and its movement is very, very important. Even in breastfeeding, the nipple should be sufficiently inside. Tongue should compress the nipple against the soft palate. when it compresses against the soft palate, the immature palate gets the pressure exerted by the tongue, and the frenum is so relieved, free, it can push the nipples against the hard palate, and the hard palate grows wider. Transverse growth of the hard palate takes place there, and you get a beautiful arch. You get all the spaces mentioned in your textbook because of the tongue goes high onto the palate. If tongue goes down, it collapses. It totally collapses there. There's no development of the maxilla. If maxilla doesn't develop, mandible can collapse there. So tongue is the scaffold to build an arch. It supports the maxilla, makes the maxilla wider cranial component. Every suture is exerts the pressure. It makes it wider. So mandible during its phase can just come forward and accommodate there. Because tongue exerts a pressure around up to 500 grams of pressure. So 500 grams of pressure is exerted by the tongue means this pressure is not onto the tooth, it is onto the skeleton, onto the cranial sutures. And the sutures, when they get this huge orthopedic pressure, they mold themselves, they become wider, they provide maxilla to become wider. A position of the bone in the suture take place, so maxilla become wider, and you can see the spaces, primate spaces can appear there. You can see physiological spaces appear, wide arch, it happens just because of the tongue exerting its pressure onto the maxilla. The suture got wide open there, all the spaces start appearing there. Tongue has to be addressed with the presence of frenum. You have to assess the frenum, and if it is required, it has to be removed there. If you do not remove that, you can see the patient progress into a class 3 pattern, hypoplastic maxilla, because tongue is not going high and exerting the pressure on the anterior part of the maxilla. So the anterior component of the maxilla collapses. On long term, entire maxilla can get collapsed into this position. And even in the permanent dentition, you can develop a hypoplastic maxilla with normal mandible. The pure reason is tongue was not high onto the palate there. So how will you correct it? You can remove the tongue tie with the help of the surgery. With the blade, you can remove the tongue tie and relieve the tongue and perform the myo exercises and bring it back normal. Or other way around is you can use lasers, bloodless, painless, simple procedure called lasers. We are going to come up next Sunday with a huge program on lasers. Amazing, changed my practice with incorporation of the lasers, especially uncooperative, apprehensive, little bit of child where we find this kind of tongue tie or lip tie or a mucocele. This is amazing soft tissue laser can be a very good adjunctive in your practice. So either you need to remove it with a blade or laser, you can do that. And once appliances like an FR3, once the crossbite is already there to correction of the crossbite, tongue was not going high. So myofunctional exercises with the myofunctional appliances like an FR3 would do, or a myobrace, different stages, myobraces are there that can do. Or sometimes if the maxillary hypoplasia is so severe, there are specific analysis to find out that, you find out, and then you rapid maxillary expansion. Dr. Biru said you expand the maxilla. Yes, you find out that maxilla is small, you expand with skeletal rapid maxillary expansions. Then something called reverse chin block, all dental correction can be done. If it is an occlusal interference, selective grinding of tooth which is causing the occlusal interference, which is forming an anterior posterior crossbite, can be selectively grinded. Or there is something called planus direct tract. Dr. Planus has devised this called planus direct composite onto the posterior molars of a primary dentition. It is done in primary dentition, not in mixed dentition, to direct the bite in such a way that mandible is held back and maxilla is promoted to come forward. That also can be done. All functional appliances here we are talking about. They do not do anything, just adjust the myofunctional part and correct the malocclusion that is developing. So you have so many options to correct it, but it is not the options to correct is important. Why it is appeared, why it is happened, correct that first and then come to the appliance therapy. I just want everyone to come to this case. One more case. Now we are going more ahead to 5 to 6 years of age. A child to 5 to 6 years of age. One more age advanced. This is a patient A of 5 to 6 years of age. Just notice the canine and the first and the second molar. Primary, first and the second molar. You need to be little more very observation in my presentation. So I make sure you are not sleeping. So I make sure you observe the presentation very well. Please observe the primary canine, upper canine and the lower canine of patient A. Also D and E, that means primary first molar and second molar of patient A. Okay, this is the right side. This is the frontal. Here, just see the canines to canine, upper canine to canine and lower canine to canine. Just observe as if you're seeing the patient there. Just observe upper canine to canine and lower canine to canine, the frontal picture. And the other side, again, I want you to observe canine, first molar and second molar. Canine, first molar and second molar. Okay, this is one situation in a patient. Now, I'm going to project one more case. Okay, just observe the picture of this case. 3 cases I'm going to put. First case, look at the frontal picture of this case, and I don't want you to see the open bite. Please do not type open bite or tongue thrusting or thumb sucking. Please do not type that. I want you to observe the canines, 4 canines of patient B. Okay, I want all of you to observe canines of patient B. Here again, canines, upper and lower canine and the molar of patient C. Here, from the central to the first molar, the central incisor, lateral incisor, canine and first molar of patient D. This requires observation. I will spend some time. So in patient A, I want you to observe the canine, upper and the lower canine, and first and the second molar. A, the frontal picture, the from canine to canine, and the left side of the same patient. On patient B, C, and D, look at the canines, look at the D and E, look at the in patient D from central to D, look at the primary delineation. Now, can you see, can anybody come to the chat box and see there? Okay, one person has rightly said in A, canine seem to be treated in case A. Dr. Sneha, very good. Dr. Sneha, I really appreciate you notice that canines in A patient is treated. Okay, that means in A, canine felt treated. Let us take some time. Do not worry. We are not rushing it out. We have time here. Canine in A is treated. Okay. So that means in B, C, and D, it is not treated. Look at that. Look at that in B, C, and D, the canines, the primary canines, even though they are in class 1 canine, but they are not treated. There is no attrition of the canine is in that case. Now, the same patient, I'm just concentrating on to the patient B. You have seen patient B here. You have seen patient B, and this is the patient B. The same patient B has come. We have started at 5 to 6 years of age. We have seen this patient at 5 to 6 years of age. This patient B, we have seen at 5 to 6 years of age. Now, the same patient B is 8 to 9 years of age. Okay, this is at 5 to 6 years. Now, the patient B is in 8 to 9 years of age. We'll just see this patient. Just see this patient. Can you see what is happening in this patient? Just have a close observation onto this patient, what is happening into this patient. If you see the canine, it's still the same. There is no attrition, nothing happening in the canine. And the malocclusion still developing like an open bite, which you have already seen there in B, that is 5 to 6 years of age, 7 to 8 or 8 to 9 years still that is happening. And there is a crowding that is happening. A crowding is also happening. So two things, additional things are happening. Canine is still the same. Shape of the canine, everything still the same. The open bite, which you have seen, also the same, almost the same, because new teeth erupting, but it's also the same. Third thing is crowding is also there. Can I get a thumbs up to what I have shown there? Okay. Can you compare with B after 2 years, 5 to 6 years we have seen him. Now 8 to 9 years, same patient we are seeing it. Can I get the findings we have find out? The canines are still the same, no much change in the canine, but there is an open bite. Early there was an open bite, still the open bite is there, but additionally there is a crowding in the lower and the upper arch is also there. Can I get a thumbs up for that so that I can make sure you're not sleeping? Can I get a thumbs up to these 3 findings of the same patient after 2 years? Okay, Dr. Pavni, thank you so much. You can find all the findings which I said. Yes, great. That's great. That's great. So that is there. Now guys, at 8 to 9 years, I advised this child something called an OPG. This is the orthopantomogram of the same child which you have seen. With this, if you see the canine, if you see the permanent canine, is totally blocked out. Upper canines are totally blocked out. Premolars are ahead of the canines, you can see. And OPG analysis, you can say it's completely a condition of a severe crowding is developing in this patient. So we saw the patient at 5 to 6 years of age. We found out the formalities, we found out the occlusion. Now we are seeing at 8 to 9 years. Okay, crowding is there. When you take an OPG, you can see a severe amount of crowding that is developing in this patient. Now, the same condition I just want to show you for a patient, which I've showed you. The A patient, same patient, A patient, which I've showed you. Now, look at the A patient. Look at the A patient. Here you can see canines are rounded off. Canines are rounded off. The sharp edges of the canines are gone. The flat C and D and D are flat. There is accretion of the primary molars are taken place. This is your crucial point of him. At age 7 years of age, we gave him best occlusion by doing pulpectomy and crowns, and we gave him, can you look into the canine? Canine are getting upgraded. He's chewing food properly on both sides. And now look at the central incisors which has erupted, which was little more crowded at the age of 5 to 6 years, but age of 7 years slowly started getting self-aligned with spaces because we established the occlusion for him. We gave him good masticatory force, let him chew on the right side, followed by the left side. The canines are getting rounded off, lateral excursion of the mandible is happening, mandible expanding sidewise, intercanine width is establishing with the occlusion. You need hard or semi-solid food to get that establishment of lateral excursion of the mandible to happen place and increase the intercanine width. With soft, semi-solid food, you cannot do that. That is the difference between the 2 cases which I said. Case B, she was not eating any solid food. She's got a habit. Along with that, patient is sticked on to soft diet. No lateral excursion of the mandible, no proper chewing of the mandible or force is exerted there. But on the other side, you can see the canine is totally chipped off or rounded off at the age of 5 to 6 years. It has to. That canine has to round up so that lateral excursion of the mandible take place. You can see, and the physiological space occurs there. Physiological space in the canine space should occur in these patients because of the occlusal forces or chewing or biting action. But patient with soft diet, it doesn't take place there. So the muscles of mastication put a pressure onto the maxilla or the mandible or endostomatognathic system, which expands the maxilla mandible three-dimensionally. And you can see the physiological spaces that is forming there. That is how the physiological spaces develops because of the proper occlusion, mastication. Canine or primate space. In primate, they chew the leaf. You go and search the primate chew the leaf, raw leaf, they chew with the masticatory muscles, and you can get the primate space. Human being are supposed to chew food and swallow, so you get that primate space, and physiological space automatically develop because of these forces exerted by that. Read this article called Physiological Tooth Migration and its significance from the development of occlusion, part 1, Biogenetic Course of Deciduous Dentition by Dr. Baum et al. Amazing article which says that spaces in the primary dentition and lack of spaces in the primary dentition is due to the occlusal forces. If you have good biting, chewing action, you will get physiological spaces. If you do not have, you will lack those spaces. Crowding in a primary dentition and a mixed dentition is not just because of arch size tooth discrepancy, it's more into the occlusion. We have to see that. So that is why he devised it into space versus non-space primary dentition. And in non-space dentition, 7 out of 10 will have crowding. In complete crowding, 10 out of 10 will have crowding. If it is space is present, physiological spaces are present, depending upon the amount of physiological space is present, you may not have crowding, or up to 5 out of 10 can have crowding. So in your initial screening, what you need to look, two things: are they eating solid or semi-solid food? Is there is physiological spaces present or not? If the spaces are present, fine. They may not develop into a crowding aspect. They are safe in their development. Now, coming to another category, 8 to 9-year-old patient. Now the child has become 8 to 9-year-old patient. This is the OPG of an 8 to 9-year-old patient. The problem is we least understood about OPG. We never indicate OPG. Even if you indicate OPG, when the OPG comes, we look as if a neurosurgeon looking at an MRI scan. We don't know what to look and where to look and how to look, what has to be seen around. So we look each other. We look at the patient, we look at the parents, we look at the patient, parents, what to say, what is happening inside, how to predict there is a possibility of developing of malocclusions present there. I will give you some simple tips of OPG science. Simple tips of an OPG science. Once you take an OPG of a 9 or 10-year-old child, look into the permanent canine. If the permanent canine is more angulated to the midline, you can now note down, please write it down. If the permanent canine is more angulated to the midline, angulation is more to the midline, believe me, that canine is going to get blocked out. Okay, that look at the other side canine, it is so straight and parallel to the midline. That is the way it has to be. That is called ugly duckling stage. It comes and hit on the root tip of the lateral, then you get auto-corrected. But this side, the canine is not getting auto-corrected. Maybe because of the retained deciduous canine, or maybe the reason. Please just see the angulation of the canine. You can tell when to extract that primary canine or what other procedure that has to be done. Look at this case. So nice the case is here. So nice it is. All the canines are almost aligned parallel. So nothing else. You don't need any analysis here. Just look into the canine angulation to the midline. That gives you a hint. If it's almost parallel, fine, it will go by itself. If it is not more angular, you have a problem here. Second thing in this OPG, look at this OPG very clearly. Look at here, you can see a primary canine is lost on one side. See, the primary canine is lost on one side and the lateral incisors is tipping onto it. Lateral incisor is getting onto the space onto the canine there. Distal tipping of the lateral incisor into the space of the primary canine is happening there. So what we should do? Look at this case. Both the primary canines are gone. Both the primary canines are exfoliated very early, and canine and the lateral has taken in the space of the primary canine there. So in those kind of situations, what can you do that? At least if you do a space maintenance, just a lingular for the lower, or a bandal loop, or a transpalatal or transpalatal arch for the upper. At least a space maintenance, if you do, you have options in future. You can save the arch in future. So space maintenance, whenever you see an early loss of canine, it would be an ideal protocol to follow to intercept the malocclusions. If you are good with that, you can do slow maxillary expansion appliances, SME, or slow maxillary expansion, amazing appliances. If you are well versed with that, expand the maxilla, mandible will follow. And young age from 7 to 8 years, if you expand maxilla, it improvises the occlusion, it improvises the nasal passage, it improvises the nasal breathing, tongue pattern, everything it improvises, because you are giving room for the maxilla. You're giving a wide room for the maxilla so the tongue can go high onto the palate. That is removable or fixed, like a quad-helix, amazing appliance, quad-helix, removable or a fixed quad-helix can do amazing function, expand the maxilla tremendously, makes the arch wider tremendously so the tongue can go high and can accommodate all the teeth and can give a good occlusion there. If not very severe, Dr. Binu was already orthopedic expansion like RME, rapid maxillary expansion, is also possible. Early age, it can give you a tremendous expansion, like good results you can give. Just see a case where total canines or laterals are blocked out, no space because of the hypoplastic maxilla. So we used a rapid maxillary expansion, split it open the maxilla. It might look ugly, but the nature takes its toll. I did not do anything, just expanded and provided room. You can see the lateral is auto erupting, and I did not do any orthodontic works here. Allowed the tooth to erupt naturally. And you can see the amazing result from this to this. So orthopedic expansion in case where you don't have space is also possible. Now, final conclusion, just 10 more minutes, please give me. I'm winding about the 10 more minutes. We are all in a dynamic equilibrium. This guy want to climb the top of the escalator, but he's in a dynamic equilibrium. He's going down, the escalator is going down and he's going up at an equal pace. The girl moving up and the escalator going down at equal pace. So there is its motion, but they are in equilibrium. This guy can never reach top. This girl can never reach top because girl is moving at the same speed of escalator coming down. It's called dynamic equilibrium. Our oral cavity also has got a dynamic equilibrium. If you see blood glucose, morning it might be down. After your breakfast, it increases. After your lunch, it might increase or decrease. Then it comes down, then it increases. It's all throughout the day, the glucose level, the cardiac cycle, the respiration, all changes according to the demand, especially same way our oral cavity, the tooth in the oral cavity is also in a dynamic equilibrium. It's like a stack of cards. This card is in equilibrium. It cannot be changed unless you put an external force to change it. If I put an external force like habits, if you put an external force like a habits, it will change. It will mold because I am putting a more pressure onto that. The stack of card which was unstable will will become unstable. So habit has got a role in developing malocclusion because tooth is developing at the center and the alveolus is developing and all the muscles surrounding it are supporting it to develop in one force. But that's called functional equilibrium. But the moment they are all in the tooth is correctly placed at the equilibrium, be an anterior teeth or a posterior teeth, they are all placed at that equilibrium. Neutral zone they are kept. But when a pressure from one side increases, the dento-alveolar structure start changing it. It mold to itself. Functional equilibrium is lost. It is in the red zone. Either tooth moves or the skeleton moves to one side. The habits can be a mouth breathing or any habits it can change the equilibrium and our body adapts to the equilibrium. So habits, whatever type of habits that you are talking about are the one that can change this equilibrium. This child wants to study, he wants to study, but he can't. He can't because the night he was opening the mouth and sleeping, he could not sleep well. So morning he gets tired, lethargic, he cannot concentrate. He's sitting in the class, teacher is telling mathematics, but he can't grasp it because he could not sleep on the night. There was not enough oxygen saturation in the blood, he can absorb it, can grasp it because he was opening the mouth and sleeping. A case of same condition, a 9-year-old child with severe mouth breathing condition came to me. Parents came to me with all the problems came to me. This was the extra oral intraoral features of the child. And this is the upper arch and the lower arch of the child. And when we take a case history, you can see all the features of a mouth breather is present here. Hypertonic lips, lip strain, adenoids, shyness, all the features, typical features of a mouth breather is present there. And symptoms, when we ask them how the child was performing, snoring is there, yes, and tooth grinding, yes, cough, yes, allergic condition, yes, she was repeatedly under systemic condition for tonsillitis, sinusitis, everything, every year 3 to 4 times she used to get antibiotics, even steroids she should take to get relieved of that. So all the condition, signs and symptoms are there. So it was come to a obstructive mouth breather. After a clinical evaluation, she came to an obstructive mouth breather. So an obstructive mouth breather, what a dentist can do? Definitely you have to report to an ENT, you get clearance from the ENT, and then it's a role of the dentist. So what we have done, 1.5 years of treatment with her with proper myofunctional therapy. The form makes the function and function makes the form concept we applied to her. And you can see 1.5 years, tremendous change in her soft tissue, skeleton, function, mastication, her academic performance, her hairstyle, her confidence in the society changed because of orofacial therapy there. What we did is a myo exercise with the oral screen or vestibular screen. You might know about it. A proper myofunction exercise with a vestibular screen appliance is done. A lip seal exercise, seal her lips and taught her to breathe through the nose, and deep breathing exercise, diaphragmatic breathing, no much of a dramatic kind of breathing, just breathe normally, but use your diaphragm and breathe. And Bodico exercises. There is something called Bodico exercises, respiratory exercises, amazing exercises, especially this post-COVID. I tell all my friends to practice Bodico exercises that can increase your lung capacity, that can reverse your lung capacity a lot. So those kind of myo exercises changed her life a lot. So appliance therapy is not the final outcome. It is much, much before identifying the reason for her condition and treating it correctly, followed by appliance therapy, which is urgent one. Next one. Talking, smiling, swallowing, chewing, you need tongue. You name it, tongue is important for doing lots of functions. It determines the posture of the mandible, determines the posture of your neck, and the accessory muscles it determines. Your suprahyoid, infrahyoid muscles are influenced by the position of the tongue. Your airway is determined by the lower airway is determined by the position of the tongue. Tongue is placed correctly, positioned correctly, function correctly, size is good, you get a good airway, you get good phonation, you get good mastication, you enjoy your life. That's importance tongue has got. Look at this child. Child came with a complaint of crooked teeth. Their complaint is crooked and crowding teeth, but on examination, tongue was low postured and thrusting of the tongue is present. Tongue thrusting is present. So tongue inside your mouth is like a tiger inside a cage. It's like a 6-foot huge tiger inside a 3-foot cage. Is accommodating inside the cage. He wants to relieve, he wants to function, he wants to perform, but he has no room to perform. The tiger is tamed there. So if the tiger inside the cage is powerful, if you do not allow him to express itself, he will express in one way. You cannot tame this guy with a tongue grip. You cannot. No matter how much of a time you try with a grip, you may not end in successful treatment. It will relapse, but you cannot tame this guy with a grip. He's a tiger inside a cage. So what we do is we start with tongue exercises. Just passionate with him, try with him, understand him, make him find out where you have to be. Tongue exercises like tongue click at the spot for 10 seconds. We start with simple tongue click exercises. Teach the time, the spot. The spot is nothing but the incisive papilla. Your upper incisor, try with your tongue and just see the incisive papilla. With the tip of the tongue, just try the incisive papilla where it is incisive papilla. Try and feel the incisive papilla. That is the spot. Ask him to find out the spot and keep the tongue tip at the spot and swallow. For 10 seconds, let him swallow for 10 times, no problem. Just keep the tongue at the tick and do a click. Just keep the tip of the tongue at the spot and do the click. Just start with this. Give him a game. This is called dental game. Let us play a game, whether mother and son has a maximum number of click at the spot. Who can do that without reducing the tonicity or frequency? Who can do that? Do some kind of game. Let the child get motivated and start doing that is the first thing. And then come 4S exercises. 4S exercises. 5 to 10 seconds each exercises. We ask them to do that. Keep the tongue at the spot which we already trained. Now they have to keep at the spot. Then we tell them to salivate, squeeze against the palate. Squeeze. That means it's not, that is over. Now keep the tongue at the spot. Okay, then salivate. So let the saliva drool in the mouth. Then ask the patient to squeeze the saliva against the palate with the tongue and swallow. That is called 4S exercises. So that is also be done. These exercises are the first we start for just to tame him, just to make him understand where are used to be there. And then give appliances like simple appliances. I don't give a crib. I stopped giving crib around 7 to 8 years back. I just make a groove where the crib is supposed to be there. I make a groove onto the spot where the groove should be there, or the spot where the tip of the tongue should be there. And I ask the lab guy to color it yellow, green, and all that color. I tell them to add that so the child can notice it. And I ask the child to keep the tip of the tongue on the groove and then do 4S exercises. So easy, so less cumbersome, not very scary for the child with that groove and spike and all. Remember, spike you give, groove you give, bar you give so much compression for the, this is for the child. It is like, oh, easy for me, I will do it. So child will take it as a challenge and he will do it. When you keep that grooves and clips and all, it's like offending him. Oh, you try to make me to stop there, I won't stop there. I will go beyond that. That's what the attitude of the child. So I do this kind of things and do. And finally, coming to the next, it's the most difficult thing to copy is a thumb sucking habit. Any age, if you see thumb sucking habit is the most difficult myofunction or the habits to be broken there. So I just want to summarize. There's no time for me. I'm just 5 minutes. I'm concluding. So 5 tips for thumb suckers. I just want to tell you, it's deep rooted habit. It is. It is not a simple crib appliance or a tie or something. It may not work out. Let me tell you 5 tips. If you find out, then I will tell you the simplest thing to break the habit. The 5 tips, if you know that up to 4 years, let him suck. Let he or her suck. Do not worry about it. Find out the stress and anxiety in this time. If a good dentist is there, let the child be ignored. Let the child suck it. Talk to the parents and find out what stress and anxiety, separated parents or uni parents or some change, something is there. So this is the time up to 4 years. It is not to treat the child, treat the parents and the caretakers. Treat them first. Child will get automatically corrected because of the stress and anxiety. Child is doing it, so treat the parents up to 4 years of age, not the child. Okay. Now, when are they sucking? After that, when are they sucking? Find out the frequency, duration, and intensity. That's very, very important. Depending upon that, you can have a manifestation after 4 years of age. You can have open bite, crowding, a lot of other functions. Secondary habits like tongue thrusting, mouth breathing can come depending upon the frequency, intensity, and duty. You have to find out that and get help. One simple request is, if you do not know, get help. Ask your specialist or ask somebody and get help. Tell the parents you need help. Tell yourself, this is not my ball game. I need help. I need to refer. Refer it. Do not ignore it. If you know it, you treat it. Otherwise, get help. Get help for the parents. Get help for a dentist who do not know. Get and refer it and get a good, secure help for the child, because it's very, very important. So if you can get the reason for that, after 3 to 4 years, the one of the best, easiest method to break the habit is let the child suck it. Tell the child you suck it. But what you do is you tie a straw on the thumb. Just try a straw on the thumb, and the outer part of the thumb straw should be outside the mouth. Now, if the child try to suck it, the air goes inside. The air goes inside. There is no lip seal. Air will automatically go because the straw is there. Straw will suck the air outside. So child will get displeasure. Oh, pleasure is less. So slowly, child will wean the habit. You don't need to know anything. One of the best method to break a thumb sucking is just try a simple straw along with that and tell the child to suck it. You suck it, child will be very happy. He'll be telling you, oh, dentist is telling me to suck the thumb. I will be very happy. He'll be sucking it. But when he sucks, he won't get the pleasure because air goes inside through the straw. That gives him less pleasure. He said, no, I'm not interested. You suck it. You promote. So he will gradually wean the habit. In early lives, it can be done. And one of the other ways, make him busy. One of the other ways, make him busy. Whichever side, whichever thumb is using the habit, make him busy so that he is preoccupied. That works wonders. Preoccupy so that he forget the habit by itself. He keeps the thumb out. So guys, finally 2 more minutes, initial screening of all these problems. You need a orthodontist or a pediatric or a general dentist need a proper screening. A proper screening for mouth breathing, which requires a detailed case history, is required. A tongue thrusting, a detailed history is required. And if you see the case history, you can see even go into the deep sleep of the patient, even the food habit of the patient, even the nature, everything is well mentioned and seen there before taking into an appliance therapy. Appliance therapy is the last one that we do. We find out the functional part first. What function is lacking in him? His breathing is lacking in him. Due to breathing, what else is lacking? His tongue is lacking or tongue function is lacking. Due to tongue function, what else is happening to him? Identify that. The reason what is happening, we find out there. Because from the initial development till the old age, old habit die hard. That's one's logo. You can take old habits die hard. Habits, no matter whatever age it is, it die hard. In young age, if you try to intercept, it's easier because it molds the skeleton. It molds the maxilla. It molds the breathing pattern. It molds your sight, it molds your ears, it molds your upper and lower respiratory tract and your posture, it molds. So that is the role of dentist. We cannot be considered as just dentist. We should be considered as oral physician because we deal with airway. We deal with the upper part of the airway, and we deal with masticatory system, the tongue, the TMJ. We deal with the maxillary bone and its relation with the cranium and the position and resorption relation to the cranium and mandible and its close relation to the cranium, and only movable bone in the cranium is the mandible and its relationship. And occlusion is the junction, is the meeting point with the neurocranium, with the viscerocranium. It's the important aspect. You have to give a stable and good occlusal plane so that patient can bite, swallow it, enjoy the food. And he posture the head with par with the entire part of the body. Posture also is corrected with our treatment. Any changes there. So we analyze a holistic part, not just the tooth. We holistically surrounding the head and neck and the body. That is called your cranio-cerviculo-mandibular system. It's a cycle. We correct entire aspect of it. And when you correct a malocclusion, we are taking into other parts of the body also into occlusion there. So let me conclude with that functional problems and form will adapt to the functional problems. So like a breathing, a tongue or a lip or a thumb, whatever functional problem happens to the muscles or to the surrounding area, there can be an adaptation to that functional problem. If airway is obstructed, the patient can automatically develop a high arched palate because he's breathing through the mouth, not to the nose, and it can lead to tooth discrepancy like deep bite, cross bite, or an open bite, and maxillary excess, a gummy smile. All those things can develop just because of that, with the retrograde mandible or prognatic mandible or a vertical growth pattern. So all are adaptation to perform the function. So if you find the form only, you can treat that form. The deep bite, I corrected the deep bite with an appliance. I corrected the mandibular retrognathusum with a pin block. I corrected the maxillary prognathusum with a headgear, reversible headgear, and corrected everything. Baba, tata, bye bye, I can say. But if you ignore the functional problem underlying which causes that problem, let me tell you, you will never end up in a successful treatment there. So it should be a teamwork where you bridge one. It's like a chain. From one slot to one slot you go. So you do not see why, you do not see how it is happening. You see why it is happening. If it is a single tooth crossbite, why that single tooth? Why the segmental crossbite has happened? Why that mandibular retrognathusm has happened? Any associated problem with that is that you go that first. Mouth breathing is present or not? Upper adenoids or upper airway is blocked or not? Lower airway is blocked or not? Posture is correct or not? See that first, and then correct the malocclusion later. So that is why we have to go a teamwork with the child, dentist, and parents, and the center is the your family or the social status at the center. You need a teamwork. It is not easy to start seeing a condition, start discussing with the parents is very important. Let me give you one simple tip here: is discussing with the parents will prove you a better result than discussing with the child or seeing the condition. And you know everything, but the parents don't know. That's utter fail it is. Sit with the parents, sit with the child, sit with the grandparents. In India, let me tell you, grandparents plays a major role. I sit with the grandparents, with the parents, and then only child is being taken into consideration, because we have to go, we have to reverse it some point of time in some cases. Once I take the grandparents into my trust, parents will follow, and after 2 to 3 days, doctor, go ahead with the protocol, we are ready. I can get the message. Then child, you can easily manipulate the child if you have a confidence to managing a pediatric cases. So that's what. So this is a teamwork to start off, and you can mold it all through the way into your private dental practice. So will this uncle will go up? I don't think so. This uncle will go up ever in his life. He can still in the life, he can still start climbing because it's in a dynamic equilibrium. Nor does this uncle or nor does auntie, we can never come down because it's in a dynamic equilibrium. So we have to understand the dynamic equilibrium that is happening. Thank you so much. So you can catch us in this platforms. We are there. We are live in Facebook, Insta, WhatsApp, mail, and our website address. You can catch us. We have given some good articles in our website. So those people who are interested, our articles will be uploaded within 12 hours from now. So amazing articles are available in our website. Log on to our website, make a point, you register there, free download of the articles which you have discussed. So you can contact us. So it's free for us, for you all. You can go to that. And now I just thank the Lincoln University, the Dean, Dr. Pushparajan sir, her patient listening from around 1 hour or so and noting down points. Thank you so much, sir. You are still our motivation, inspiration. And Dr. Deepu and his team, sorry, Gobu and his team for working hard to make this very productive. Now, so we are open to question and answers. Is over to Dr. Joe. Are you there?
Yeah, Javi. Yeah, I'm here, Javi. We will take
Dr.
we'll take up. There are some questions in the chat box. We'll take up the question in 2 minutes time. Before that, just want to tell you about the competition we had launched a month before. That was a competition for the dental fraternity all around the world who went through lockdown period. We know we all went through this lockdown period. It was a painful time, and the whole world was affected. And it is one of its kind. My father, my grandfather, nobody has seen such a stuff. We all went through something really, really rare. Now, we dentists managed to get out of it. We are now getting back into our practice. But what we did during that lockdown period, we decided to open up a competition, a 30 seconds video by the candidates, by the dentists on what they did during the lockdown period. We got amazing response, excellent videos, 30-second beautiful videos, touching videos. Everybody was so overwhelmed with the concept because they were so close to the family during the lockdown period. Many people said they had dinner together for the first time during that lockdown period. Otherwise, like father in one room, mother in another room, kids in another room with Wi-Fi. It all changed. We were all together. Pets became closer. Gardening. We got lots of videos. Dr. Joby, can you just put on that video? Just a glimpse of some of the videos here. We have arranged here. Here you go. Just some glimpse of some videos which we got. Can we play it?
Yeah.
Yes, thank you. That was just a compilation of more than 50 videos we got, but around 15 or 17 are actually selected as the finalists because there were some copyright issues for many of the videos. It's still open. Those who want to send in their videos, whatever you did during lockdown period, just compile it into a 30-second video, send it across, and great prizes are awaiting you because the Cordon company has taken up this event completely, and they are giving a loop, a working loop with light as first prize, and then the patient motivation brush, 4,000 rupee worth TP brushes are being given to give out to your patients as second prize. So a lot of prizes awaiting. Please go ahead and put it. Tomorrow onwards, as promised, all the selected videos will come in Facebook. Judges are watching. Judges are judging it in 50-50 proportion, where the number of Facebook likes are also being taken into consideration. So go ahead, please post it immediately. Few more days to go till we finalize the final 3 winners. Thank you very much on that. Dr. Joby, can we take up some questions now?
Yeah.
The chat box is kind of full. So, sir, reason for children pouching food?
The reason for children pouch, there are 2 reasons. One reason is maybe a child is having caries in one side, so it is very sensitive. So he uses the other side because he's scared to take the food onto the other side. So he keeps the food on one side. So one reason, you just check into dental caries or food impaction on one side. If you rectify with fillings or whatever treatments, then he will do that. Second reason is delayed introduction of food. Many parents delay the introduction of semi-solid foods into the child. If you delay that, the child will used to get into a pattern, a learned pattern of using the soft, the breast milk or the bottle milk or the soups or all those kind of things. So they can get into a learned pattern of getting soft food. So suddenly, if you give a hard food, what the child will do is you will start keep the food there, let it get softened and melted, and then chew. That would be one other reason for that. So what
How
you
to,
do?
yeah.
Yeah,
How
go
to
ahead.
correct lower bilateral, lower anterior crossbite in 5-year-old child with primary teeth?
Yes, that is what exactly I told you here. First and the foremost is you have to look for the reason for that crossbite. If it is an occlusal interference, which I already mentioned, if there is a sharp lateral incisor or a canine, sharp canine, if it is present, then you could do a selective grinding on the respective part, will take care about it naturally. You don't have to worry about it, just remove that. Second thing is promote semi-solid and hard foods. We have seen automatically the bite get changed when you introduce semi-solid and hard food for the child, chewing pattern of the child.
How to
Then
correct crossbite canine to canine in 4-year-old?
exactly, we already mentioned that. One more thing in to add on to that is there's something called selective grinding. Selective grinding is for that you have to find out the food pattern of the child. If it is semi-solid or solid food, or child is not chewing into that, you have to promote that, followed by the sharpness of the inclines of the canine, first and the second molar has to be reduced onto the side where the child is not using, both working and non-working side you have to use it. And if you reduce that, that will promote more flatter occlusal surface, which enables the child to chew more and help them to grind both sides. So that itself will remove a cross bites in young dentition. If required, if you see that if it is very severe and if you require an appliance therapy like an expansion or those things can be done if the child is cooperative. Till the child is not cooperative, you can resort into this selective grinding. You can even use hard foods which promote chewing, can itself bring a lots and lots of changes onto the occlusion.
So which arch expansion appliance is preferred for anterior crowding without posterior crossbite?
Arch expansion, if you talk about, if it's depends upon the incisor inclination. If the incisors is retroclined, if you just want to torque incisors, let me tell you, Frankel's FR3 is one of the best appliances. If you can do, Dr. Frankel is clearly mentioned, if it's a dental kind of crossbite that has happened, it's my appliance is the best because it tip the anteriors, upper anteriors, and stimulate the anterior part of the jaw. It can be done if it is used the tipping of the upper anteriors. If it's a true skeletal kind of maxillary deficiencies present on the anterior arch, then you might have to go for your rapid maxillary expansion kind of, because that is what newer archival analysis will give you that.
Sir, how to manage maxillary protrusion with increased overjet and lower incisors touching the hard palate?
How to manage maxillary
Protrusion. It's basically a severely protruded case with the lower teeth touching the palate. Severe deep bite.
Okay, so severe deep bite with maxillary excess there, right? Okay, so in this kind of conditions, you just find out the mandibular condition there. So this can be due to a mandible which has been locked behind at an early age also, because 3 years of age, up to 3 to 4 years of age, mandibular growth is also there, which has been retruded. That is also one reason. So usually what we do for this age group is we will allow the man to disocclude the mandible. Just allow the mandible. Just give any kind of appliances or a posterior biplane, or just put some composites on the posterior aspects of the upper posterior teeth. Just allow the mandible to come forward, allow the mandible to grow in the next one. Then you can see a tremendous improvement in the change in these cases.
Will arch expansion of maxillary arch causes the mandibular arch to expand as well, or do we have to expand the mandibular arch separately?
Usually you start the treatment at an early age. 99% if you expand maxilla, mandible will follow.
So what is the indication of lower Schwartz appliance? In a case requiring only mandibular space regaining, is there anything to do for maxilla?
I think a Schwartz appliance is the removal, this one.
Yeah, what is the indication for lower Schwartz appliance?
Lower
that is
Schwartz.
one question. And the next question, in a case requiring only mandibular space regaining, is there anything to do for maxilla?
And mandibular space regaining, if you want a sagittal, more amount of space required in the mandible, definitely your Schwartz in the maxilla is not going to help, and Schwartz in the mandible is not going to help. Here you need space regainers. Literally see the position of the molars of the mandible. If they are tipped or migrated forward, need space, you have to push it bodily back. So you need a 2x4 with a coil spring kind of things to push it back. You cannot expand mandible within your limited scopes because the sutures are fused. So dentoalveolar expansion of the mandible with the help of a Schwartz appliance is possible, but within limited range. If it is more, then you have to take your 2x4 utility arch or kind of coil spring, open or coil spring, closed coil spring, or whatever, to push or distalize the molars back at an early age will be very protective.
Please repeat the name of the exercise to increase the lung capacity.
Oh, that is lung capacity. Butico lung exercise is the one. To tell you very simple, you breathe 2 times normally. Okay, 2 times normally you breathe. At the end of your expiration, close your nose. At the end of expiration, close your nose. See how much you can hold the breath. See how much you can hold the breath. If you can hold the breath up to 45 seconds and more, you are a master. You may not have any cardiac diseases, you may not have any dementia, you may not have any Parkinsonism, you may not have any kind of neurological disorder, cardiac disorder, diabetic disorder, with thyroid disorder, kidney disorder. If you can keep it more than 45 seconds after normal expiration. If it is less than 20, you need to improvise it. Check your BP, check your sugar, check everything possible if it is below 20 seconds.
What's the right age to start with expansion in child?
A expansion in the child is dentoalveolar at any age. Skeletal expansion, let me tell you, 7, 8, depending upon the skeletal discrepancy. Maxilla should be treated early.
Sir, if there is 3 to 4 millimeter crowding in upper arch anterior, if you want to align by 2x4 appliance, how to get space? Is it with SME appliances?
Either you can use a combination or 3 to 4 mm, and what is the age of the child is determined.
No, that's not given there. That's not given.
So the growth of the mandible maxilla is also taken into consideration, but you don't straight away start with a 2x4. I think you go for an SME and then you go for 2x4. I think Dr. Binu will be covering this in the next free session, and followed by the paid webinar. He will be explaining all these things in detail, very detailed there.
Yeah, once you talk about 2x4, it is purely dental movement we are talking about. And to move
Exactly.
we need space. So I
Yes.
think before doing any movement, create space. That's a protocol. Sir, please explain about planus direct tracks.
Oh, doctor, that requires a one-day class. How to keep it and how to, which molars, which inclined planes, and the diagnosis is much more. There are courses done by Dr. Ramesh. It's there. You can search it. You can. I mean, it's very expensive, but I told you it's requires a 2 to 3 day program to do. But it's an amazing appliance. Dr. Planas in Brazil has started this just to disocclude the maxilla and mandible and direct growth into a reverse twin block direction. Exactly, reverse twin block is the concept.
How does I3 appliance for an anterior crossbite work? Do we need bite openers on the lower posteriors?
I3 are, they are myofunction appliances specifically designed for class 3. So there are 3 appliances, start off with 3 years, 4 years. There is called I3, then comes the triangle cage, and then the retention appliance. 3 type of appliances are there. So you start off with I3, which position the mandible exactly the same way FR3 position. Nothing apart from FR3. All thing is because of that soft silicone appliances, it's very compatible to the patient or easily acceptable to the patient. FR3, when you show patients, oh my God, such a huge appliance, so much wire, so much thing, how will my child wear? It's all that. But the functional aspect is exactly the same, because you have to do all the function with I3 and FR3 the same. The swallowing, the talking, the chewing, everything has to be done with the same.
Which is the best age to intervene for arch expansion if, in spite of the patients at the age of 11 and there is no much space for permanent canines to erupt? Should we wait for physiological intercanine width to happen?
Physiological intercanine is already happened by 8, 9, 10, it is done. 11 years is already over. Now, if canine is blocked out or you need space, and if the child's profile allows and you have scope for expansion, then rapid maxillary expansion is only option there. Slow maxillary may not provide you sufficient space. Better than that, you pull out the premolar and align the canine there and finish it off.
I guess we are pretty much done, Javi. Rest all our excellent presentation. Every time we listen to you, it is a new thing. Thanks a lot. Thanks for the presentation. So that's it. We are done. Dr. Pushparan, sir, we are officially done. Dr. Gobu, we are officially done. Thank you, one and all, for trusting us, coming again in huge numbers. And let's hope and pray that this union with Lincoln University will go forward in many more years to come. And we'll have more and more of classes, variety classes coming up. Dr. Pushparan, sir, can we wind up? Call it a day.
Sir is muted. Sir and Gobu is muted.
Sir is muted. Sir, you have to unmute, sir. Dr. Gobu, Dr.
Yes,
Pushparan, sir, yes.
Yes, doctor. Thank you. Thank you very much for a wonderful presentation and very informative. I wish a great success and hoping to go forward and I hope all our colleagues will be benefited. And let's move forward with the paid version and also the constant free versions. All the best for online dentistry.
We are looking forward for the offline version in Malaysia. We need a trip to Malaysia too.
Sure.
Right. Thank you so much. Right, Ravi? Isn't it time to get out of
Yeah,
here?
yes, yes.
More than one and a
Yes,
half
sir.
hours.
Yes, sir.
Doctor,
Pushparan, sir.
You were telling something about the breathing.
Yes, sir.
It does not go only for the children, even for the adults, you can hold for about 40
100%,
seconds.
sir. Yes, sir.
Yeah, I normally hold for about 60 seconds between one breath to another breath. Take through the right nostril, inhale deeply, hold it for 60 seconds, exhale for about 60 seconds, and then keep in shunya, that is without any air in the lungs. We must keep for a couple of counts, and then we must go through the left nostril.
Yes.
This will definitely increase the lung capacity for the children as well as for the adults.
100%.
And that is one of the way by which we can avoid the present COVID also.
Exactly.
Okay.
Exactly, sir. Exactly.
Still recollect you said about when you came to Alva, I still recollect the wordings you said. You get up at 4 a.m. every day, whatever it may be. Even after our classes were like 12-hour classes, still next day morning you got up at 4 a.m. for doing your yoga and the routine stuff.
Sure, sir.
Great, sir. You are a motivation, sir. Great.
Thank you very much.
All right.
Hope you will see again.
All right. Thank you very much.
Okay,
for
sir.
calling
Thank
today.
you. Thank you.
Yeah. Bye.
Thank you. Thank you all. Thank you.